Okay, thanks for joining us for Teaching Tuesday. Some people have been asking about inverted nipples, so I want to tell you a little bit about how I address that. There are various, like a lot of things, there are various degrees or grading scales of what we do, how much drooping of breast, and etc. Well, there's a grading scale for how inverted nipples are. Normally, you'd want the base of it at the areola to be flat, and then the nipple projects, different sizes, different amounts, but that would be normal. Then there's some amounts of inversion. Some is just a tiny little bit, like you're looking at it, is that inverted? And then some are inverted enough and tethered in, you can't even grab it and pull it out, and you can't see it at all. You'd have to sort of pull the skin out to find it. Well, depending on the degree of inversion, that's how we decide sort of how aggressive the procedure is. Right, you have a mildly inverted nipple, someone's there for an implant anyways, you put an implant in, and it's going to push the nipple out. Sometimes it's a little worse than that, and we'll actually put something underneath the nipple directly to push it out. I guess you could inject a filler. I like to sometimes inject fat, or you can take a dermis from skin from somewhere else in the crease or something and make like a little ball of that and an incision on the side, put that in and sort of stiffen things up and push out the nipple areolar complex. But in the more severe cases, you have to understand that what's keeping the nipple inverted is some of the connective tissue around the milk ducts, right? And that's why you can't pull it forward. So in some situations, we have to actually sort of divide those ducts and then do a procedure, even sometimes with the skin around the areola, to sort of make sort of like a hammock underneath to pull the nipple areolar complex forward, like sort of a foundation for it, and then maybe even add some volume under there too. Why not do that in everyone? Because there are nerves coming through there with that connective tissue and the nipple ducts too. So, I mean, that's it. That's pretty much how I look at treating inverted nipples, from the simplest situations with a little inversion to the most difficult. Thanks.